Welcome back to the Radiology Advances podcast. Today we're analyzing a piece of research called Visual Language Artificial Intelligence System for Knee Radiograph Diagnosis and Interpretation, a collaborative system with humans. It's by doctors Hay, Stewart, Liu, and colleagues from Harvard Medical School and Massachusetts General Hospital in Boston, Massachusetts.
Our mission today is to unpack the technical side of their RadGPT system, how it actually fuses image analysis with the power of a large language model, and maybe the most crucial part, how they built in this mandatory human collaboration step. That's key for stabilizing results and ensuring quality.
And they built this on a really solid foundation. We're talking about a huge retrospective collection spanning 2 decades, 2001 right up to 2022, including 22,512 knee radiographs. That's over 77,000 individual images, all from Massachusetts General Hospital.
Yeah, that's a deep well of data. It gives you the kind of clinical variability you really need to train a system like this properly.
Okay, so let's dig into the architecture. The authors hit 2 big real-world problems right away. First, standard LLMs are text-only. They can't inherently see or quantify subtle things on an X-ray, like joint space narrowing. And second, from a practical clinic standpoint, you just can't be sending vast amounts of sensitive patient data to external servers. There are privacy risks, plus it's just too slow.
Exactly, and that's where the RadGPT solution is quite elegant, I think. It's about localization and a hybrid approach. They set up a local, secure environment, and for the LLM, they used a fine-tuned version of the open-source llama model called Vicuna. So this local LLM gets paired with a sophisticated visual module, a vision transformer, or VIT, and an MLP classifier. This creates a system that can interpret the image pixels and structure the language output. The whole workflow has 3 main steps.
Right. Step 1 is the AI doing the initial diagnosis. Here, the visual module predicts probabilities for 15 key diagnostic features, things like a fracture, osteoarthritis, arthroplasty, a whole list. Then step 2, and this feels like the core innovation, interactive refinement. This is that human-in-the-loop part you mentioned. It's not optional. The user has to review and can modify those initial 15 AI predictions.
Precisely. And then the final step, number 3, is the output. Radiological image interpretation. The local LLM takes those refined human-checked findings and basically translates them into a proper professionally structured radiology report. They used 2 different readers, a radiology resident with 2 years experience and an expert fellowship-trained musculoskeletal radiologist over 7 years of practice.
And here's the bit that makes it potentially workable in a busy clinic. The time it took, that interactive refinement step, reviewing and tweaking the 15 AI predictions, it only took about 45 to 60 seconds per case on average.
Yeah, that's a tiny time investment.
For potentially huge gains, right? Which brings us neatly to the performance metrics. How well did it actually do?
So they used area under the curve, AUC, as the main performance measure, standard metric. The initial AI-only results, they're okay. Respectable for some things, but they fell short of clinical expectations for quite a few features. But then adding that human collaboration step, it improved performance across the board. With the human input factored in, the final AUC scores ranged from 0.76 for osteonecrosis, which is tricky, up to a really excellent 0.91 for arthroplasty.
Okay, that's already a strong improvement. But the really interesting part is, whose input made the biggest difference? You mentioned the 2 experts. User 1, the resident, gave moderate improvements, but User 2, the fellowship-trained MSK radiologist, their input led to statistically significant improvements in 13 out of the 15 categories compared to just the AI. That's quite a difference. The AUC for osteoarthritis detection had jumped from 0.73, which is okay-ish, to 0.90. That's a huge leap, and maybe even more striking, effusion. That went from 0.67 to 0.90.
It highlights the power of high-quality human expertise guiding the machine. But here's where we need to pause and look at a really crucial detail in the data, something every trainee should think about carefully. If the subspecialist's input is so valuable, you probably expect the 2 human readers to agree a lot, right?
You would think so, yeah.
But that wasn't really the case. If you look at Gouet's agreement coefficient, the AC1 value, which measures how much the two humans agreed before the AI refinement, it was actually surprisingly low for some common, often subjective findings. For osteoarthritis, the AC1 was just 0.17, and for joint space narrowing, even lower, 0.06. Very little agreement on the case level.
That low AC1 reflects just how much variability, how much subjectivity there is in human interpretation. Yet their input, especially the experts, dramatically boosts the model's objective feature-level diagnostic performance. How does that work?
Exactly. RadGPT isn't just averaging their opinions or taking a simple consensus. It seems like it's using the high-quality, experienced input, user input, to sort of stabilize the system. It's almost like it's learning the best available pattern for those subtle or subjective findings from the expert. The system seems to transform that variable, noisy human case judgment into more robust, objectively measured feature probabilities. It kind of dampens the human noise floor.
So it's not just about accuracy. It's about consistency, too. Now, beyond the diagnosis itself, did this hybrid model actually write good reports? They check that too, right? Using standard text metrics.
RadGPT significantly outperformed the baseline general LLM they compared it to, which was Mini GPT-4, across the metrics. And again, RadGPT paired with User 2, the MSK expert, achieved the highest scores. That indicates better content alignment, better semantic relevance compared to the original human-written reports used as reference. Generic LLMs often miss the nuance, the severity, but RadGPT, especially after refinement, could accurately capture the degree of a finding. For instance, specifying moderate effusion instead of just saying effusion is present.
Ah, okay. That level of specificity is crucial in a real report. Avoids ambiguity.
Exactly. It makes the report genuinely useful for the referring clinician.
So let's pivot to the practical side for our listeners. For you as a future clinician, what does a system like RadGPT actually mean? The authors are clear it's an augmentation tool, right? Not a replacement.
Absolutely not a replacement. It's more like assistance.
So, for maybe less experienced readers, trainees, or perhaps general radiologists reading MSK cases, RadGPT seems like it could be a really valuable diagnostic assistant, potentially raising diagnostic consistency.
For sure. And for the highly trained subspecialists, the value proposition shifts a bit, but it's still compelling. For them, it becomes more of an efficiency tool. Think about high-volume reading lists. If you can add just 45 to 60 seconds of review time per case and potentially get diagnostic AUC gains of up to 0.23 in common categories like effusion, that seems like a worthwhile trade-off. It streamlines reporting without sacrificing and potentially even improving accuracy.
That balance is key. And they gave us a peek under the hood, too, using attention maps to see how RadGPT arrived at its conclusion.
Yes, and it's quite insightful because it mirrors human reasoning in some ways for findings that are pretty obvious on the X-ray, advanced OA, big osteophytes, maybe surgical hardware. The model's attention maps showed it relied heavily on the vision transformer. The image features dominate it.
Makes sense. It saw the obvious thing.
Right. But for more subtle findings, things that are hard to definitively see on a plain film, maybe an implied soft tissue injury where the X-ray is technically negative, the model's attention shifted. It started relying more heavily on the LLM part, the contextual reasoning, and the language it generated often recommended further assessment, like an MRI maybe.
Which is exactly what a human radiologist does, right? Uses logical reasoning when the visual evidence is equivocal or suggests something unseen.
Precisely. It mimics that thought process. Okay, the X-ray doesn't show a fracture, but given the context or subtle signs, maybe we should recommend looking further.
So to wrap up this section, the RadGPT study really shows a successful blend of visual AI and language modeling. But the key takeaway seems to be that deliberate, structured human interaction is what unlocks the superior performance, both for diagnosis and for report quality.
Definitely. That human-in-the-loop component isn't just a feature, it seems essential based on this work. Which brings us to the final crucial point, limitations in future. What do you need to consider before something like this could be widely adopted? The authors themselves are very upfront about two major limitations. First, and this is a big one, the model was trained exclusively on single-center data from MGH.
Right. Huge data set, but all from one place.
Exactly. So while it's large, its generalizability is unknown right now. That's challenge number one. The second limitation is about what the AI was trained to look for. The keyword set itself. Those 15 diagnostic categories cover a lot of common ground: OA, effusion, fractures, etc., high-frequency stuff. But critically, the current set omits certain low-prevalence but clinically devastating findings, like lytic or sclerotic lesions that could indicate a primary bone tumor or maybe metastasis. For RadGPT or any similar tool to be truly useful as a primary reading assistant at an expert level, it must be expanded. The keyword set, the training data, it all needs to incorporate these critical diagnoses reliably. A human radiologist absolutely cannot miss those, and neither can a trusted AI assistant.
That really frames the path forward then. Rigorous external validation on diverse data sets, and crucially, expanding the model's scope to include those rare but vital diagnoses. Well, this has been a fascinating introduction to RadGPT. If you found this episode informative or have any other feedback, please rate, review, and subscribe. It helps more people discover the podcast and supports the broader conversation around innovation in imaging. You can read the full article and explore more great content on the journal website. This episode was generated with the help of AI, but all content was reviewed and verified by editor Dr. Nelson Gill from Massachusetts General Hospital for accuracy. Thanks for joining us.